The next speaker, Dr. Tagalakis from Montreal. She's going to talk about the VT treatment in cancer patients, emerging the role of DOACs and LMWH heparins.
Thank you, Mr. Chairman. It is indeed a pleasure to be here today to speak to you concerning the emerging role of the direct oral anticoagulants versus low molecular weight heparin. So my objectives are twofold today. First, to review the emerging data for DOACs in cancer-associated thrombosis, and secondly, to discuss anticoagulation options for cancer-associated thrombosis, really recognizing the cancer subgroups that are at risk for both bleeding and recurrence, and trying to come to some sort of understanding as to how we can best tailor therapy for our patients. These are my disclosures. So the treatment of cancer-associated thrombosis has really been dictated over the past 15 to 20 years based on standard sort of clinical guidelines that have helped physicians determine how best to treat their patients. And low molecular weight heparin monotherapy is considered the first-line therapy for cancer-associated thrombosis and is endorsed by several guidelines, both local and international guidelines. However, in the past few years, we've had emerging therapy with the oral direct anticoagulants coming on board and being assessed in the realm of cancer-associated thrombosis. These can be described as a single oral drug approach, which is very attractive to both physicians and patients, and it's based on the premise that there's an higher initial dose. So let's look at two specific trials as Dr. Carrier mentioned earlier. I'll be focusing on the two latest trials that were both first presented last year in December at the American Society of Hematology. We'll first begin with SELECT-D, which was a pilot trial that looked at rivaroxaban versus low molecular weight heparin, specifically at dalteparin. So it was a prospective randomized study, open label, phase 3. It was a pilot study which enrolled 406 patients with active cancer and symptomatic DVT and or NEPE with a fairly good ECOG status. And these patients were randomized to receive either rivaroxaban 15 milligrams BID for 21 days, followed by 20 milligrams once a day, versus dalteparin at the standard dosing of 200 international units per kilo for the first 30 days, followed by stepping down the dose to 150 international units per kilo once a day, and treatment duration was for 6 months. And the primary outcome was to assess VT recurrence in cancer patients with the first VT treated with rivaroxaban or dalteparin, and of course to assess rates of major and clinically relevant non-major bleeding. These are quickly the results of the study. You can see here, looking at VT recurrence within the 6 months, that there were 18 patients who developed a recurrence versus 6 patients in the rivaroxaban group. If we look at the 6-month VT recurrence rate, we see that it was 11% in the dalteparin group versus 4% in the rivaroxaban group, which gave a hazards ratio of 0.43 that was statistically significant, with a confidence interval ranging between 0.19 to 0.99. If we then looked at the bottom part of the table, we see that major bleeding occurred in 6 patients on the dalteparin arm versus 11 patients in the rivaroxaban group. So that's 3% versus 5%. And we see an even wider disparity between the two groups when we look at clinically relevant non-major bleeding, where it was 3% in the dalteparin group versus 12% in the rivaroxaban group. Total bleeding, combining both of these bleeding outcomes, ended up being 6% in the dalteparin group versus almost more than 2 times the risk in the rivaroxaban group at 17%. Most of the major bleeds were of gastrointestinal origin or gastrointestinal bleeding, and there were no central nervous system bleeds. Now, there are some limitations or considerations or perhaps nuances to the study that need to be taken into account. First, this was a pilot study. It was never intended to be just a first part where there was randomization to rivaroxaban versus dalteparin, and then there was a stratification after 6 months where patients were then selected to go onto anticoagulant therapy. Given that the small number or the slow recruitment of this study, it ended up being shorter with a smaller sample size. Along the way, GI malignancies were excluded because the DMSB, or the Data Monitoring Safety Board, noted that there was an excess amount of GI malignancy bleeding. And so a decision was made during the trial to exclude patients with GI malignancy. An interesting fact, or an observation, is the fact that many of these patients, the qualifying VT was an incidental VT. So over 50% of patients entered this trial with an incidental VT, which is a little bit different than what we're used to with our past studies, particularly the low molecular weight cancer-associated thrombosis studies that have been done in the past, where incidental VT did not compromise such a big part of the study population. And of course, one of the limitations that I think both this study and the next study that I'll talk about, we still do not have good data beyond 6-month treatment duration, as these patients, the follow-up ended at 6 months. And a key burning question for many of us who are treating patients with cancer-associated thrombosis is what really to do beyond 6 months. So now let's look at the other trial that was presented in December 2017, and that's the Hokusai VT cancer trial that compared edoxaban versus low molecular weight heparin. So once again, the study design was open label, a non-inferiority trial with over 1,000 patients with cancer who had acute symptomatic or incidental VTE, were randomized to receive edoxaban 60 milligrams once a day versus dalteparin, once again, the 200 international units per kilo for 1 month, followed by 150 international units per kilo for the following determination of a study duration. Treatment duration was at least 6 months and up to 12 months. The intent was to go to 12 months, but as we'll see later, on average, or the median duration of time was around 6 months. This was an interesting primary outcome that was used by the investigators. It was for the first time we're seeing a composite outcome of recurrent VTE, or thromboembolism, or major bleeding. So the combined outcomes of major bleeding and recurrent VTE was put together and became the primary outcome. It was felt that both clinicians, whether oncologists or hematologists or internists who were taking care of these patients, would really care equally whether their patient developed a recurrent event or whether their patient had a major bleed. So this is an interesting nuance to the study that I think is actually a very intuitive and very understandable for many of us who are treating these patients. I should note that the dose for edoxaban could have been reduced to 30 milligrams once a day in patients who had either a creatinine clearance between 30 to 50 mils per minute, or the body weight was less than 60 kilos, or in those who were receiving concomitant treatment with potent P-glycoprotein inhibitors. And these are the results here presented for the composite outcome for edoxaban versus dalteparin. We see that the composite outcome occurred in 67 patients in the edoxaban group for 12.8% risk versus 71% in the dalteparin group for a risk of 13.5%. We see that the hazard ratio was 0.97 with a confidence interval that crossed unity, showing us that edoxaban is not inferior to dalteparin, so similarly similar to dalteparin vis-a-vis the primary outcome. But let's look at recurrent VT and major bleeding. Let's break down the composite outcome, looking at these two other outcomes. So looking at recurrent VT, we see that edoxaban arm, there were 41 recurrent VT episodes for a 7.9% risk versus 59 events in the dalteparin group for an 11.3% risk. And here we see that the hazard ratio was 0.71 with a confidence interval that crosses unity. And so for recurrent VTE, we see that the patients had edoxaban was not inferior to dalteparin. When we look at major bleeding, we see that there was a difference vis-a-vis major bleeding. In patients in the edoxaban group, 36 patients developed major bleeding for a rate of 6.9% versus 21 patients in the dalteparin group for a rate of 4%. And so there was an excess bleeding for a hazard ratio of 1.77 that with a statistically significant confidence interval where there was more bleeding in the edoxaban group. And when we look at the breakdown, we see clinically relevant non-major bleeding also occurred more frequently in the patients with edoxaban versus dalteparin, as well as major bleeding and combined clinically relevant major bleeding. Similar rates were seen. When we break down the major bleeding and look at gastrointestinal bleeding, there was a concern. There was a flag here. It looked like in the edoxaban group, most of the bleeds were upper GI or lower GI type bleeding. Similarly, we saw this in the dalteparin arm, but there were a lot more in the edoxaban group. And so for major bleeding, we have the hazard ratio there, and most of it was being driven by upper GI or lower GI bleeds. Let's look at the patient characteristics a little bit and treatment duration in these two groups. I've highlighted there four interesting characteristics that I'd like to highlight. Once again, as we saw in the SELECT-D trial, we see that symptomatic VTE comprised around 68% in both treatment arms. So incidental VTE was likely around 30% in these two arms, similar to the SELECT-D trial and very different from what we were used to before in the other trials with the low molecular weight heparin. Moreover, when we look at creatinine clearance, we see between 30 to 50 mils per minute, we see very few patients were enrolled with these types of creatinine clearances. And that is an issue for many of us who treat our cancer patients who end up getting exposed to different cancer chemotherapeutic agents, end up undergoing surgical procedures, end up being hospitalized, where kidney function can often be affected. We also look at platelets between 50 to 100. We only had very few patients in this trial who had platelet counts between 50 to 100. Below 50, patients were excluded from this trial, but we wanted to know more about patients between 50 and 100, and we see that we had very few of those types of patients enrolled. And finally, as I alluded to earlier, treatment duration was significantly limited in the sense the 12-month duration is not something that was attained by many patients in this trial, with an average of 211 days in the edoxaban group versus 184 days in the dalteparin group. So the conclusions from the Hokusai VTE cancer was that edoxaban was non-inferior to dalteparin for the primary outcome of recurrent VTE or major bleeding, but we did see that there was a lower rate of recurrent VTE observed with the edoxaban group, but was offset by similar increase in risk of major bleeding in that group. And most of this bleeding was mostly upper gastrointestinal bleeding, and mainly in patients with gastrointestinal cancer. What about these limitations or considerations that we need to point out here? I think, once again, an open label concept is always something that can be argued vis-a-vis a limitation in a study, although difficult to do a non-open label study when using an injectable. Limited data beyond 6 months, once again, many of us want to know how to treat our patients beyond 6 months, and yet we didn't have a lot of patients in this study who went beyond 6 months. And once again, the qualifying VT, there was a large proportion that was incidental. So when I look at this, and I'm very excited that we have the direct oral anticoagulants and they've shown such promising results in these studies, I think about what these data are speaking to vis-a-vis patient characteristics or patient subgroups that potentially would make me favor low molecular weight heparin usage over a direct oral anticoagulant. I think direct oral anticoagulants are quite beneficial for our patients with cancer-associated thrombosis, but perhaps for not all patients. So one of the things I think should be considered is that GI malignancy or genitourinary malignancies, as a lot of clinically relevant non-major bleeding was seen in GU malignancy type patients. Recent or prior GI bleed should be considered when choosing a low molecular weight heparin, gastrointestinal mucositis, significant gastrointestinal surgery or malabsorption, specific drug interactions with your anti-cancer therapies, looking at thrombocytopenia, renal impairment, antiplatelet use, and bleeding risk factors. I've highlighted there because there have been subgroup analyses of the Hokusai VT cancer safety population that have looked at other types of patients within the study that could be considered to be at higher risk of bleeding. And we do see there that certain cancers like urothelial cancer, there was a higher risk of bleeding in the edoxaban group versus dalteparin. Creatinine clearance between 30 to 50 mils per minute occurred between 10.5% in the edoxaban group versus 2.9%, and so on. So the key factors that sort of showed a trend towards increased risk and not statistically significant, however, were platelets 50 to 100, antiplatelet use, more than 3 bleeding risk factors, which included antiplatelet use, NSAID use, renal dysfunction, for example, and more than 4 bleeding risk factors. So finally, when I look at these clinical considerations, or my personal sort of way at addressing how to manage a patient with cancer-associated thrombosis, I do believe that DOACs are an emerging therapy for cancer-associated therapy. Guidelines, however, still recommend, as Dr. Carrier noted earlier, low molecular weight monotherapy as first-line therapy. We have and continue to have very limited data beyond the 6 months for secondary prevention with a direct oral anticoagulant, much less than we do with low molecular weight heparin. And I think one of the things that the studies have really highlighted to me and many of my colleagues is that we should consider, as physicians treating patients with cancer-associated thrombosis, how best to tailor the anticoagulant management of these patients toward the risk of recurrence and bleeding. So it's a balancing act that we have to be able to understand the data, understand how these drugs work, to be able to fit it to our patient. And so if I move on to what I think should potentially be something I would recommend in my practice, is that from avoiding direct oral anticoagulants in certain gastrointestinal cancers and potentially genitourinary cancer, I would consider low molecular weight heparin in patients with renal impairment. As I showed you, there were very few patients with creatinine clearances between 30 and 50 mils per minute. I would consider drug-drug interactions when choosing a direct oral anticoagulant, and I would consider low molecular weight heparin if there is high-risk features for bleeding. And some of these are listed here, such as prior bleeding, thrombocytopenia, and antiplatelet usage. Of course, patient consideration comes into effect. What the patient prefers. There are types of insurance coverage for the medications that are available to you also play an important role. And we also have to remember that the extremes of body weights, we don't have a lot of data with the direct oral anticoagulants. We may have a little bit more data with low molecular weight heparin, but certainly vis-a-vis the anticoagulants as a whole, the information we have is quite limited in extreme body weight. So that's something that you as a physician will have to really consider when choosing the right drug for the right patient. Thank you.
Thanks very much, Vicky, for your nice presentation. Again, another easy and clinical question. How can we measure the risk of bleeding in our cancer patients? We have other tools in other settings. Can we use these other tools in cancer patients, or we need a specific model for bleeding in cancer?
I think that is the sort of, if I may say, the term holy grail vis-a-vis addressing how best to determine the anticoagulant management of these patients, understanding what their risk of recurrence is and understanding what their risk of major bleeding is. After all, today we heard at the ISTH subcommittee on malignancy that it's all about, the focus now is going to be on us determining what the risk of bleeding is in these patients to be able to pick the right anticoagulant. There are some risk assessment models that have been developed in the cancer patient population to determine risk of recurrence and risk of major bleeding, but unfortunately these have not been well validated and often can be quite complicated to use in our patients. But I think the understanding here is, just like there are risk assessment models for determining the first incident VTE, you think about this as patient-specific risk factors, cancer-specific risk factors, and biomarkers, or even in the future, genetic-based biomarkers that can be put together to help you determine risk of recurrence and risk of bleeding. But at this point in time, I think many of us work more on understanding intuitively what increases somebody's risk of recurrence and bleeding, and often, surprisingly, they're competing. Advanced stage is a risk of, it confers an increased risk of recurrence, but also confers an increased risk of major bleeding. Renal failure, there's increasing data that shows us that that is associated with an increasing risk of recurrence, but as I've shown, also increases the risk of bleeding. So physicians are left trying to balance these, and in my clinic, it's always the focus of mine in trying to best deal with my patients. But it is something that I think we need to be able to further refine down the future. And I think the answer is going to be that we're going to have to do it by specific cancer types because it's such a varied population and we're dealing with patients that have already had a VT event. And so competing risk is an important aspect to these patients, and it may be difficult to find a score that fits everyone.
Thank you very much.